Good morning, and thank you for joining us in our latest webinar in our 2024 series. If you've joined us on previous webinars, it's good to see you again, but if this is your first time, it's great to have you with us today. Please, if you've got any suggestions about topics for our webinars next year, please put them in the feedback form that will appear at the end. It's only a few questions. It won't take you very long at all, but we would appreciate some feedback. Today, we're joined by Paul Taylor, Clinical Director and Co-founder of Odstock Medical Ltd. It's going to be an introduction to FES with an update on research and clinical guidelines, followed by a Q&A session. If you have any questions, please put them in the Q&A section at the bottom of the screen. Don't put questions in the chat or we might miss them, but do feel free to use the chat to one another and say hello and say where you're watching from today. So just some housekeeping before we let Paul loose. The session is being recorded today, so you'll be able to watch it again later. But the only people that will appear on camera will be myself and Paul, and we'll, of course, let you know in due time when it is available to watch on our YouTube channel. And as I said, use the chat functions to chat to one another, use the Q&A functions if you've got any questions, and I will ask Paul at the end of his presentation. So now I will hand you over to Paul to do his presentation. Hello, Paul.
Oh, okay. I'll see if I can share my screen. This is where the technology usually breaks down. Okay, are you able to see my screen? Okay, hopefully you can.
Yes.
Good. Okay, so my name's Paul Taylor. I'm a consultant clinical scientist at Salisbury District Hospital. I'm also clinical director of Odstock Medical Ltd. Now, Odstock Medical Ltd is one of those unusual things. It's a private company owned by an NHS trust. So it's a company that was set up by the hospital to take the research work that we're done in the Department of Clinical Science and Engineering at Salisbury District Hospital and take it to the wider NHS and overseas in some cases as well. Okay, so FES is a means of getting movements in weak or paralyzed muscles, and it's most commonly used for correction of drop foot. So in this example, you see a gentleman who's got a drop foot. He's actually due to MS in this case, but it's very similar to stroke in this respect. And you can see he's dragging his foot. We're now going to turn the stimulation on, and you can see stimulation is causing the foot to lift as it swung forward. So walking is safer and quicker, less effort, altogether better. I'll just run that again with a little bit quick maybe. So we're stimulating a nerve at the side of the leg. So we have the nerve comes down the back of the leg, swings round to the front of the leg, just below the head of the fibular bone. So the fibular bone is the bone that runs up the outside of your lower leg, and there's a little knobbly bit at the top, which is where the nerve is. And so this is really useful. You can use this bone to locate where the nerve is. We put sticky pads over the nerve and the muscle, and we turn the stimulation on and off at the right time through the gait cycle using a small pressure pad, which is normally placed under the heel on an insole. The stimulation starts when the foot comes off the ground. It's ramped up so it makes it a bit more comfortable. It stays on until the foot returns to the ground. There's a little extension period which gives you ankle stability at when the foot hits the ground, and then it ramps down. Okay, so the main aspect of electrical stimulation is that it improves the safety of the swing phase of gait. So if I just look at this video, it's just another example. Again, a lady with multiple sclerosis. You can see that the foot is being dragged along the ground. And if there was anything in the way, they would be tripping over that. So she's now going to turn the stimulator on in a minute. There we go. And you can see the foot's lifted. You can see daylight under the foot. And she's obviously a lot more mobile. Another example of the same effect, this lady with the stroke again, you can see that her foot is barely leaving the ground. And again, she'd be at risk of tripping over objects if they're in the way. And now with the stimulator turned on, you can see the foot is clearing the ground much more easily. You also see that she's looking straight ahead of herself. She's no longer looking down at the ground because she's confident that she's not going to be tripping over the floor. Electrical stimulation also helps when the foot is placed on the ground. So another example, another lady with stroke, you look at her walking, you can see that her foot is lifting, and when she puts it down on the ground, she's weight bearing through the outside border of her foot. And this means that she's at risk of going over on her ankle, and that puts her at risk of falls. When she turns the stimulator on, the angle of the foot is changed, and she's now weight bearing through the middle of the foot, and this makes walking an awful lot safer. Another example of the same thing, this gentleman's had a head injury, and you can see again he's weight bearing on the outside of the foot. Turns the stimulator on, and angle of the foot changes, and so he's much safer, as well as getting better ground clearance. FES can also help with control of the knee movement. So this example is someone walking again with stroke, and you can see that he's dragging his foot, and his knee is quite straight. He's also being closely looked after by his wife, who is not letting him out of her sight. Okay, if we now turn the stimulator on, hopefully you'll see that there's a bit more knee movement this time. Walking's a lot quicker and faster, and you can also see that he's now wife-free, or perhaps his wife is now more independent of him. Okay, so FES has a broader effect than just lifting the foot in the stance phase, the swing phase. One final example of walking. This is a lady who's got systemic lupus erythemia, which is a blood clotting condition which effectively can cause multiple small strokes. And in her case, it's left her with bilateral drop foot. So this is her walking at the beginning. I apologize, it's quite an old video, but you can see she's dragging both feet. Walking is quite hard. Now with the AFO below knee calipers that she was issued with prior to coming to our clinic. This is with FES on both sides. You can see she's lifting her foot a lot more easily. And then this is 3 months later, sorry, she's able to do away with the clutches and use walking sticks. And this is 6 months later. She's now only using FES on one side and just one walking stick. So that's her progression over 6 months of treatment. Okay, FES is a nice recommended treatment. Guidelines are IPG 278, and they say that FES can be used in the NHS. That doesn't mean to say that it has to be used, and different local authorities can choose whether they fund FES or not. But now the majority or just over the majority, do fund FES to some extent. General precautions with FES, it's really quite a safe intervention. There's not much that can go wrong. If you are a pacemaker user, then additional checks need to be made to make sure that the FES doesn't interfere with the pacemaker. It's unlikely, and we've not come across a case yet, but it is a check that we need to do to make sure it's safe. The effects of FES in pregnancy isn't really understood. No one has done the detailed studies needed to demonstrate safety, and nobody wants to get sued, so it's generally not used in pregnancy. There's some evidence that people with poorly controlled epilepsy may get increased symptoms of seizures when FES is used. It's not well proven, but we've seen a few cases in our clinic. So our general rule is if someone has had epilepsy in the past, they need to be stable on medication for about 3 months before trying FES to demonstrate that they're in a stable condition. A more practical thing is poor skin condition. The one complication we see with FES is skin irritation to the electrodes. And it's one of the things we monitor in our clinic. And apparently we see this in about 2% of patients who come to clinic. So it's something that we can manage in most cases, but it is something that you have to be careful about. And very occasionally it can be a reason for stopping using electrical stimulation. You should never put electrodes over broken skin, so cuts, spots, rashes, and that sort of thing. You should avoid stimulating over them. Okay, so what happens if you're referred for FES? So the normal route to receiving FES is to have a referral by a GP or in some areas physiotherapists. Or you can also self-refer if you are going down the privately funded route. I would say the majority of our patients are NHS patients. So we look at the referral to see if FES is likely to be a suitable treatment for you. We'll then invite you to an assessment clinic, and we'll check everything we need to check clinically, and we'll try the stimulator to see if it is of benefit. Now, in most cases, we will see a benefit straight away. So it's something that you will be able to appreciate at that session, and we will get a good idea of whether FES is likely to be a suitable thing for you. We then ask you back for 2 clinic appointments, usually scheduled within about 1 week. And we teach you how to use the device, and we refine the settings for you. And we also take some outcome measures to record the effect of the stimulation on your walking. We'll then do follow-up sessions, usually 6 weeks later, 3 months after that, 6 months after that, and then yearly for as long as you're using FES. And all of that is done as an outpatient clinic. If you have problems in the meantime, we encourage you to contact us, and we will either try and solve problems over the phone or Zoom or WhatsApp these days, or we'll ask you to come in for an extra appointment to sort out the problems. So the current cost of treatment, whether you're a private patient or the cost to the NHS, is just under £2,500 in the first year, and then £617 a year thereafter. And that covers all the costs of the appointments, the equipment, consumables, any repairs or anything that's required. So, as I said, we use skin surface electrodes, and a typical set would be, as demonstrated here, we have, hang on, So the yellow hexagon represents where the tip of the fibula bone is, and generally you'll place one electrode over that area, and the other electrode over the muscle which lifts your foot. Is the muscle called the anterior tibialis. There's an exam at the end if you want to take the test. And that's a standard position for most patients. If we need more knee flexion and hip flexion, we can place one electrode at the back of the knee, and that will give us a stronger response and lift the foot a bit more. A variation on that is to place one electrode at the back of the knee, which is over the same nerve, but also one at the front of the leg over the tibialis anterior muscle. That will again give you a slightly different effect with more foot lift and perhaps a little less eversion, which is the twisting of the foot out to the side. We can also stimulate over the muscle directly, and this is for people who already have stable ankles and don't need the movement out to the side to stabilize their foot. We can also stimulate other muscles in walking if they're required. For example, stimulating the calf muscle to help push the body forward as you take a step. We can stimulate the quadriceps muscles to prevent the knee from flexing while you're standing. We can stimulate the muscles at the back of the leg to improve knee movements in flexion. And we can also stimulate the muscles around the hip, the gluteus medius and maximus, to extend and stabilize the hip. And all these can be done in walking using the same device. It's very important to learn where to place your electrodes. And this is an example of a photograph that was issued to a patient earlier this year. We generally will give photographs to patients to show where to place the electrodes. And here I've marked on the electrode where that bone is. So if you were to press the 4/4 of the electrode, you would feel it slightly harder where it's shaded because the bone is under the skin, and then softer at the other three corners. I was explaining this to a patient many years ago now, and they're saying, you press here and it's hard, and then it's soft, soft, soft. And he said to me, "You're just like the small boy of the toilet paper advert." I said, "What?" And at the time, there was an advert on television which there was a toddler, 2-year-old toddler, watering trees, and to prove how sustainable the toilet paper company was. And his catchphrase was "soft, soft, soft." So that's somewhat embarrassing for me, but if it helps remind people where to place the electrodes correctly, then that's a good thing. We can also point at other landmarks, like this gentleman had a very useful freckle close to where the electrode needs to go. And pointing out the electrodes here for him were 2 finger breadths apart. And then if you look at the other side, you can see that the row of dots is where the tibia bone is. So if you pressed along here, you'd feel the hard bone underneath the skin. And the other electrode is placed about 1 finger's breadth from that bone. So if you're systematic with placing the electrodes, and use what's called anatomical landmarks, i.e. feeling for where these bones are, getting the electrodes in a repeatable, reliable position is normally okay for most patients. So there are some couple of variations to the stimulator. So it can be used with a wireless foot switch. So this little device here on the shoe is what's called a link. It's a little wireless transmitter, and it takes the signal from the foot switch and transmits it to the stimulator, which could be on your leg or it could be in your pocket. There's also the possibility of using a remote control to turn the stimulation on and off and turn it up and down. This is useful if you have the stimulator under clothing. And a lot of people these days will carry the stimulator in what's called an OML sleeve or a paste sleeve, which is based on the leg over the electrodes. And they're available in different sizes to fit different sizes of legs. Okay, so what's the evidence for FES? Well, it's been going quite a long time now. We did the first ever randomized controlled trial of the technique back in 1997, or it was published in 1997. And this was what's called a randomized controlled trial with stroke patients in Salisbury. We had one group who received a stimulator, and the other group received physiotherapy. Uh, uh, and then we compared the effect, and we saw that the walking speed when they used the stimulator increased. This also was the case in several other studies since then. We've seen the effect demonstrated repeatedly with other stroke patients and also in other patient groups like multiple sclerosis or Parkinson's disease patients. There's also a training effect, and we looked at the training effect by looking at the effect on walking speed. And we find that the walking speed increases uh, after they've used the stimulator for a while, even when they're not wearing the stimulator. And this, we were the first team in the world, I think, to demonstrate this. Walking speed is an important parameter in itself. You may not be concerned about walking faster, but if you're able to walk faster, it demonstrates that you have improved walking quality and you're less likely to fall. You're more likely to be able to walk further. So it's a good overall assessment of your walking quality. And it's been suggested that it's the sixth vital sign, and it's something which is a good indicator of general health. Other effects, we've seen increased walking distance as demonstrated by measuring the distance walked in 6 minutes. We also see a reduced effort of walking. This has been done in a number of different ways. Firstly, we showed it by demonstrating that the heart rate was lower compared to walking speed when FES was used compared to walking without FES. And that's a technique called physiological cost index. It's also been shown that the oxygen consumed by a person while walking with FES is lower than when walking without FES. And this indicates that the muscles are not working as hard, not using up as much energy because walking is more efficient when FES is used. In our original study, we also looked at spasticity, and we found that general extensor spasticity reduced in the lower limb after FES was used. So going back to walking speed, this is a graph of the change in walking speed for people who have dropped foot due to stroke. And the dark blue line is the change in walking speed with the stimulator turned on. And the light blue line is the change in walking speed when the stimulator is turned off. So you can see that on day one, people walked about 11% fast straight away. And then after 18 weeks or 4.5 months, when we measured it again, their walking speed had increased by about 22% in comparison to when they started. When the stimulator was turned off, they also saw an increase of nearly 10% in their walking speed, indicating a general training effect from using the device. And then when we followed up this group of people a year later, 72 weeks from starting, we found that the effects had been maintained and the stimulator continued to work the same. So the difference between the two lines, we call that orthotic gain, and that's the sort of benefit that you get from the stimulator as if it was being used as an orthosis. Then the difference between baseline and the lighter blue line is the training effect. So that's the improvement you've had as a therapeutic effect. And then the total orthotic effect is the overall improvements, summing the two things together. I know this is a stroke seminar, but we also have the same data for MS, and we do see something slightly different in MS. The difference between walking with and without FES is still very large, but we don't see a training effect with people with MS, and this is because the neurological problems are somewhat different to stroke. But it's still a very effective walking aid and is used by many people with MS. Other effects from stimulation, well, we see an increase in safety. We've done, I think, 3 studies altogether which have shown reduced falls in FES users compared to people receiving just physiotherapy alone. And the figure is about 72% fewer falls when FES is used. There's a study done by Kim in Canada, and they showed that FES produced better ground clearance than an ankle foot orthosis. That's a splint in your shoe. If you ask an FES user the difference it makes to them, the answer you get back pretty much more than any other is that it makes them feel more confident. And every FES appointment we do, we'll always ask people to summarize the effects of FES, and this is what we very commonly hear. Confidence needs a little bit unpacking. I think it relates to the fact that people feel safer. They feel they're less likely to fall. They feel they can walk further, so they know they're going to be able to complete what they intend to do. And they know that it's going to be less effort, so it's not going to be as tiring. We've done questionnaires which have shown that patients feel more independent from using FES, and you saw in one of the videos earlier that people perhaps need less close attention from partners or carers because they're much more safer while walking. Greater participation, that means doing more things in daily life, whether that's tasks around the house or going to work or going shopping. Data shows that people are able to do more when they've used FES. And all these things lead to an overall improvement in quality of life, which has been showed by multiple questionnaires. Finally, from an NHS point of view, FES has shown to be cost effective within the terms used by NICE. So, and this is one of the reasons why it's an accepted treatment within the NHS in many areas of the country. And there's one study which says that it can be cost effective compared to an ankle foot orthosis. Okay, so how long do patients use FES for? Well, we looked at all the patients who started using FES in our clinic in the year 1999, so it's quite a long time ago. We then followed them up, looking for when they had their last appointment follow-up, and this would enable us to calculate how long they used the stimulator. So each of those dots is when a FES user stopped using FES. Until you get to the end of the graph where it says still using FES, those are people who've had their last appointments but were continuing to use FES. So you can see that the average FES use was about 5 years, both for stroke and MS patients, and that enabled us to calculate the average cost per patient, and this is used again to justify it to the NHS as a treatment that can be used. So why are people stopping? Well, some people improved, so they no longer needed FES. Other people had other health problems, maybe further strokes, uh, uh, or just the general life problems that people have. So there's multiple different reasons for stopping FES. Some people decided they didn't like it, but that's a minority. Does FES continue to work the same way for as long as it's used? So again, this is walking speed data. So the red dots are walking speed results taken with while wearing FES, and then the blue dots is with when the FES is turned off. And from that, we can calculate the average improvement in walking speed um, uh, over the lifetime that the stimulator is used. And you can see that in this graph, the dotted black line is a changing walking speed with FES turned off, and the red line is changing walking speed with FES turned on. And so although the data is a little bit noisy, it goes up and down a little bit, the main message is that the gap between the two lines stays about the same for as long as the device is used. And this is using data all the way up to nearly 11 years from the beginning of treatment. And the effect is similar with MS, but we see that we don't get that training effect that we see in MS, in stroke patients. Sorry. So what do people think? Well, at the end of the day, it's what the customer, the patient thinks about the treatment. And these are some of the comments back from some of our FES users. And you can see that they're quite positive. It changed my life. 1 minute I was struggling around walking with a stick, and the next I could walk without it. It gave me confidence. I'm no longer dependent on other people. I can just go. Another comment, the OT pace has given me my life back, and I can't imagine life without it. I'm now able to do things around the house like cooking, cleaning. It stops me from relying on people all the time. And another one, in past, I've walked more in the past week since I've had the stimulator than I have all year. My stick is now redundant. We get some good reviews. Okay. One thing that's changed in the national guidelines in the last couple of years is the recommendations to use FES also in the upper limb, so for trying to improve hand and arm function. So the new edition of the stroke guidelines, which was published last year, now has recommendations for managing shoulder pain, managing spasticity, and also training muscles. Now, shoulder subluxation can be a significant problem for some people with stroke. And shoulder subluxation is when the muscles around the shoulder are very weak or paralyzed, and the muscle stretch and the distance between the bone and the clavicle at the top it increases. So as that stretches everything out, and it's associated with a lot of pain. So in this X-ray, you can see quite a big difference between the top of the humerus and the clavicle at the top. Now, the patient is wearing electrodes. That's what these wires are on the outside of the body. And when the stimulator is turned on, you can see that the humerus is lifted towards the clavicle, and the gap disappears. So I have a video of that. So this is one of our patients using FES. And you can see that the shoulder shape is quite hollow here. It's when we turn the stimulator on, the whole shape of the shoulder changes. At this point, it's turned up a little bit high, so we turn it down again. And that lifts the shoulder back into its normal position. Now we do this with a 2-channel stimulator called a microstim. And so we're stimulating 2 pairs of muscles, one electrode at the front, one at the back for the posterior and anterior deltoids, and the other over the middle deltoid and a muscle called the supraspinatus on the top of the shoulder. And we swap over the 2 pairs of muscles so that one set of muscles is given a rest, and then the other set of muscles is given a rest, but the shoulder stays in the same position. Now, the main effect we find with this is that it's very effective at reducing shoulder pain associated with shoulder subluxation. And it's one of the few treatments that I'm involved in where I can be pretty confident saying this treatment will definitely reduce the pain of your shoulder. And it's very good to see that it's now made into the guidelines. That's stimulation turned off at the air then. So that's one of the options which is now becoming available. Another application we use in the upper limb is to try and improve hand opening, often a common problem in stroke. And so here you can see standard electrode positions over the muscles which open the hand and extend the fingers. And we've called this the rule of 3 fingers. So basically, if you line 3 fingers up with your parallel to your wrist and then place the electrode the other side of that, and then another 3 fingers gap and place the electrode slightly to the outside of the arm, you will generally have the right electrode position to open the hand and relax the stiffness of the hand. There is some evidence that exercising long-term can improve the function, so you may be able to open your hand voluntarily yourself more easily. But generally speaking, you need to have a little bit of movement at the beginning before, if you have no movement whatsoever, generally speaking, you won't get an improvement in voluntary function, but you may still get a relaxation of the hand and so less spasticity. And there's how you might adjust the electrode position to get sort of fine-tune the effect. Okay, so as I said, Odstock Medical, NHS-owned company owned by Salisbury NHS Foundation Trust. It was started in 2006, and it runs the FES service and also makes stimulators which are sold primarily to other NHS hospitals. We have, so on the map you'll see blue stars, that's is NHS hospitals that we work with, and the yellow stars are OML outreach clinics. So these are clinics that are organized by OML, and the way that works is that a referral is sent to Salisbury. We will then assess the referral to see if it's appropriate and then send it on to the nearest clinic to the person where you're living. As you can see, we have centres across the UK from Scotland down to Cornwall, Kent, Northern Ireland, Norwich, and we're always looking at to start new clinics as well. So you can find out information about that on odstockmedical.com, or you can phone up our manager who looks after that, Abby Kane. Either phone her on 01722 439 565, or you can email her directly on abby.kane@odstockmedical.com, and she'll be able to tell you where the nearest clinic is to you and what you need to obtain treatment. Okay, that's all I plan to say. So if you have any questions, I would be very pleased to answer any questions that you have. So please fire away.
Thank you, Paul. That was really interesting. And just a reminder to you all that the recording will be available. So all these details, who to reach out to and the phone numbers, etc., you'll be able to get them from the recording. We had a few questions come in before today. I've got two that I think Paul answered for me beforehand. My husband had a stroke 2023. Will he be able to gain any movement in his left leg with this aid? And will an FES help somebody walk a little bit further, despite them going to the gym to try and improve their walking? And you suggested, Paul, that they come in for a personal assessment, which is free.
Yes, so all initial assessments, face-to-face initial assessments are free, regardless whether it's NHS or privately funded treatment. So it's always worth coming to see us and seeing if FES is the right thing for you. So going to the questions, generally speaking, if someone is able to walk a little bit, FES will normally enable them to improve on that. So they'll be able to walk further and faster. But obviously for an individual, we would have to assess that to know if it's right for you. I've forgotten what the other question was now. Sorry.
I think it was the one about helping somebody managing to walk a little bit further. Would it stimulate their muscles to help them walk for a little bit further?
Yes, I mean, generally that is exactly what we find. So where we are not able to help is where people who aren't able to walk at all. The FES is something which will help people who walk badly walk a little better. If you're not able to walk at all, it's unlikely to be of sufficient help to enable you to walk. So that's sort of the lowest level of ability. You need to be able to walk a few meters, albeit with a walking stick or walking frame, but or a splint, or all three of those at the same time. Then we'd be able to improve how much walking you would be able to do. At the other end of the spectrum, there are people who only require assistance with walking when they're tired. So they may not have a drop foot all the time, but the stimulation can also be helpful for them because they can turn on the device perhaps later in the day when they're tired and use it just part of the time. They don't have to use it all the time. So it's quite a flexible system in that way that you can use it when you need it. You don't have to use it all the time.
Brilliant, thank you. The next one, how do you suggest therapists optimize intensity and frequency of FES in busy clinical environments?
Okay, this is quite a complicated question. So FES can be used in a number of different environments. So all our clinics are outpatient clinics. People are taught how to use the equipment, which they then use at home. So it's used primarily an assisted device for improving walking while you're walking, although it will, in most cases, have some training effect at the same time. So in those cases, people are just using it whenever it's helping their walking. And for at least half the people, that's using it every day, possibly whenever they're walking in that day. FES also has a role in rehabilitation immediately after stroke. And this can help initiate walking after stroke, help retrain the muscles. FES will generally always strengthen muscles, increase the size of muscles if it's used regularly enough. Like all therapy, you need to do it fairly regularly. Doing it once a week is usually not sufficient to have an effect. It's something that's better used daily, and consequently, it's a treatment which is which is often self-managed by the patient, set up by the physiotherapist, but then managed by the patient, so they use it without direct supervision all the time. I hope that answers the question.
Right, the next one. A professor at the University of Bournemouth says 2 hours FES is needed from 2 weeks post-stroke to prevent degradation. What's your view?
Okay. The very first study I ever worked on, research study, wasn't with stroke, but it was spinal cord injury. And we measured the muscle loss people had after the spinal cord injury. And we found that in the first 3 to 4 weeks of their injury, they lost about just over 40% of their muscle. We measure that using ultrasound. So when you have something that gives you paralysis, whether it's stroke or spinal cord injury, and you're on bed rest for an extended time, the muscles will waste away fairly quickly. And we also showed in one of our studies that that can be reversed with electrical stimulation, taking it back up to normal levels. So Professor Planian is correct that using electrical stimulation in the early stages of stroke can strengthen muscles and may improve the rate at which people return to function. The exact details of that, I think, are still to be worked out. I think there's scope for further research in that area. But it's undoubtedly true that using FES early can reverse the muscle loss and muscle weakness that is typically seen after long bed rest.
Okay, thank you.
Yeah.
And on to the questions we've had today.
Okay.
Are you ready for
Yeah,
these?
that's right.
Is there a drop foot FES device that can be used to help walking every day?
Yes. So our devices are designed to be used as take-home devices which you use every day. Yes. So we did a survey well, quite some time ago, and I think it was 55% of our patients were using it every day, about a third, sort of maybe half the week, and the minority perhaps 1 or 2 days a week. So it's something which is used very regularly, yes.
Okay, the next one. When is FES most effective? For example, I'm 20 months post-stroke. I've reasonably good movement in knee and dropped foot, but when I get tired, it gets much worse. To put that in context, I often walk the dog 3 miles a day.
Okay, so that would be um, uh, you'd be the sort of person who would probably put the stimulator on to wear it, but then only turn it on when you needed it. And I had several patients over the years who have described their situation very similarly. They get tired after walking the dog and turn it on to get home. And yes, it's made their dog fitter because they can walk further.
It's all about the dogs.
Yes.
Right, the next one. Can it help with chronic knee and calf pain and altered sensation following brain hemorrhage and consequently stroke? Mine 6 years ago, age 52. How to get guidance on location of pads on skin. I've tried occasionally, live in Scotland, so not sure what's available.
Okay, on control of pain, well, I can only speak generally because I don't know enough about your individual case to give firm advice. But we do find that it can reduce pain, and there's been a couple of studies where that has been demonstrated. Um, uh, there are studies, not with our device, but with other device, where patients have calf pain due to something called intermittent claudication, which is a cardiovascular problem. And they've used stimulation to improve symptoms successfully. So that's been done. We do see with our patients that there's a training effect on sensory awareness. So patients report they feel more aware of their affective side. And we think that's just because the repeated stimulation has a training effect on the sensory awareness, and that might improve proprioception. Um, in terms of advice on electropads, well, the best advice is to get referred to one of our clinics. We do have outreach clinics in Glasgow, Aberdeen, and Edinburgh. Um, there are, uh, and they hopefully would give you expert advice on exactly how to use FES. I hesitate to say look at web pages because it's always best to get direct clinical advice, but there is a one of the electrode manufacturers called Excelgard have a web page with advice on electrode placement, which is quite good.
Excellent, thank you. The next one is any advice on how to work towards not needing to use the FES? It's what I'm aiming for.
Okay, this is a good question, and I think it's something which we need to do more research on to, find the best way of doing this. But the general principle is that you need to practice walking both with and without the stimulator. So, firstly, from a daily life point of view, safety of your walking and everything, you need to use the FES when it makes your walking safer and more efficient. But it's a good idea to practice in safe environments, just walking a little bit without it. Um, or even try just turning the stimulation down a little bit, so you're walking with a slightly weaker stimulation. Uh, um, the general guidance on neuroplasticity, so training, retraining your movements, is that you need to put lots of voluntary effort into doing the effort, doing the movement, and it's likely that combining that with FES at the same time may boost the training effect. So yes, it is just keeping going and trying and practicing. Uh, I've got, and as I say, I think we need to improve how we do it. That's the general advice.
Lovely, thank you. And the last one, I think possibly for today, it said, is
Okay.
it normal to experience bruising over site of electrodes?
No, it's not. It occasionally happens. I remember one patient a long time ago who was a type 1 diabetic, and in diabetes, you can have problems with the skin capillaries. And when you take an electrode off your skin, it can be quite sticky and can pull on the skin. And if you've got very fragile skin, that can be enough to cause some bruising. But it is quite unusual. So uh, I would speak to your physio FEF clinician about that and get some advice specific to you.
Okay, lovely. Hopefully, let me just check. Yep, that's all of them done. Well, all that leaves me to do is say thank you very much for this insight into FES, and hopefully we've answered a few questions you know, that people have about it and everything. So again, everybody, you will get notification of when this recording's up so you can watch it again and go through it, because I appreciate it's a lot to take in one go, and all the vital questions of who to get in touch with and the phone numbers and everything. So thank you very much, Paul. If you have any further questions, please email us at different strokes and we can pass them on to whoever needs to answer them. And please stay on and fill in your feedback form. It'll be very, very quick. It's only four easy questions. And our next webinar is coming up in December, on the 2nd of December. And that's on well-being after a stroke. And the lady presenting it is Charlotte Fisher, who's a stroke survivor herself. And after her stroke, she got very interested in looking into well-being after a stroke, and actually did some research on it for a degree. And so she's going to be sharing this with us and offering some practical ways that everyone can either practice well-being on themselves or helping others with it. So please keep an eye on our website and our social media for when you can sign up for that. That'll be very soon. And as usual, any questions you have before it, please ask them, but obviously there'll be Q&A again. So once again, many thanks to you all for attending today, and many thanks to you, Paul. It's been fantastic. Thank you.
No, thank you for inviting me. It's been a pleasure.
Thank you.